Welcome to this channel made for me. In this video, we will talk about the febrile neutropenia. Um, all the information which I will give here is taken from Harrison and Davidson. So let's start. So first of all, we know that the normal levels of neutrophils and granulocytes. So normal levels of granulocyte is more than 2000 per microliter, and neutrophils normal level is more than 1500 per microliter. So in case of febrile neutropenia means value less than 1500 per microliter, and in case of febrile neutropenia this neutrophil level is decreased to less than 500 per microliter. And according to Davidson, the definition of febrile neutropenia is taken as if there is clinical presentation of fever and granulocyte count less than 1500 per microliter is known as febrile neutropenia. And in case of this Davidson, the febrile neutropenia definition is written as if there is fever along with neutrophil count less than 500 per microliter, then it is febrile neutropenia. Or if the neutrophil count is less than 1000 per microliter and it is expected to decrease to less than 500 per microliter within 48 hours, then it is also known as febrile neutropenia. As we all know that the neutrophils are the first defense of the body. So if the level of neutrophil decreases, then there is high risk of infection. So and infection can be viral infection, it can be bacterial infection, it can be fungal infection, and the most common infection is the bacterial infection. In bacterial infection, the most common organisms are both gram positive and gram negative organisms, and in those the most common is Pseudomonas aeruginosa. Pseudomonas aeruginosa. So the antibiotic which we will give will mostly target the gram positive and gram negative organisms and Pseudomonas aeruginosa. But in later cases, when the antibiotic could not decrease the infection and the risk is very higher, like the duration prolongs to more than 5 to 7 days, then we have to add antifungal agent because the fungal infection may predominate at that time. Now we will talk about the causes of febrile neutropenia. So the patient who are suffering from cancer, they are at risk of febrile neutropenia, and the person who are undergone the cytotoxic chemotherapy. So the first common cause described is the complication of malignancy. First cause is the complication of malignancy, and the second cause is secondary to cytotoxic chemotherapy. And cytotoxic to chemotherapy, radiotherapy. During radiotherapy, we irradiate the bone marrow, or we irradiate the cancer cells. So at that time, if large amount of bone marrow is irradiated, then there can be chance of febrile neutropenia. So radiotherapy. Also it can occur in case of pancytopenia. In which case this pancytopenia occurs like if there is aplastic anemia, if there is aplastic anemia, or there can be bone marrow failure, or if there is bone marrow metastasis. So these are the three causes which can cause the febrile neutropenia. Now we will learn about the different clinical presentations which the patient present. So its clinical feature, the most common clinical feature is the high fever. But if the patient is taking paracetamol, then it can be masked. The symptoms can be masked, and it is also associated with feeling of unwell. If patient does not feel well, feeling of unwell, and sometimes it can cause hypotension. If there is hypotension, then there can be the systemic circulatory shutdown. Systemic circulatory shutdown, which can lead to organ failure. So this clinical feature which I have told here is it is taken from Davidson. Now we'll learn about the different investigations which we have to send. So the different investigations will be as we normally do, like we send a complete blood count. We have to send blood culture, and then urine culture and sensitivity, and then chest x-ray, and then swabs. We send different swabs for culture. These swabs are usually taken from throat, if there is any central line, then from there, and if there is any wound, in order to locate the site of the infection. Now we'll talk about the treatment, but before going to the treatment, I would like to explain one score which is MASCC score, which means that Multinational Association of Supportive Care in Cancer. So according to this score, we select the antibiotic up to which duration and what antibiotic we should give. So according to this score, I will not talk in detail. I will just summarize. If the score is more than 21, then there is low risk febrile neutropenia, and if the score is less than 21, then there is high risk febrile neutropenia. We have to know this. And I need to mention one thing again, and which is this fever. In case of fever, if there is single oral temperature, if single oral temperature is more than 38.3 degrees centigrade, or if temperature more than 38 degrees centigrade lasting for more than 1 hour, then we include this definition of fever in case of febrile neutropenia. And now we will talk about the treatment. So in case of this febrile neutropenia, there is a very high risk of infection. So antibiotic therapy is initiated, and a very high dose of antibiotics and very high dose of IV antibiotic. IV antibiotic is started within 1 hour. Without awaiting the results. And first we give empirical therapy, then later according to the culture we give the specific therapy. Okay, now in case of this febrile neutropenia, there is high risk of gram positive and gram negative, including pseudomonas aeruginosa infection. So we choose the anti-pseudomonal drugs and other the broad spectrum antibiotics. So for the bacterial, so for bacterial infection, what we choose is that we choose in Harrison, there includes the 3 drugs. One is the ceftazidime or cefepime. Another is piperacillin tazobactam. Piperacillin tazobactam. And third drug includes imipenem or cilastin or meropenem. Here the imipenem or cilastin, it can cause Clostridium difficile diarrhea. So this imipenem or cilastin is not the preferred one for this febrile neutropenia, and these carbapenem groups of drug, carbapenem group of drugs, they are usually reserved for the gram-negative bacteria. They are usually reserved for the gram-negative bacteria. Now, this antibiotic treatment, according to 1970 study, it was mentioned that the antibiotic treatment is given till neutropenia resolve, which means that the granulocyte count more than 1500 per microliter for at least 2 days. But according to this recent studies, it is mentioned that stop antibiotic treatment if patient is afebrile, and is stable after 72 hours of treatment. So this is the recent one. Now, and if we suspect the coagulase negative staphylococci staph aureus, like how we suspect like if there is erythema, at site of catheter, or if there is positive culture of MASCC, then we suspect coagulase negative staphylococcus aureus. So we have to add vancomycin. And the bacterial spectrum also differs from hospital to hospital. So we have to choose antibiotic according to the most common organisms in which are common in the hospitals. And this is the chart which I have taken it from the Harrison. I mean to say that from this chart, the initial therapy we started with antibiotic, which is effective against both gram-positive and gram-negative organisms. And if the obvious sites are found, then we treat the infection with the best available antibiotics, and we do not narrow the spectrum unnecessarily, and we continue to treat for both gram-positive and gram-negative aerobes until neutropenia resolve or granulocyte count more than 500 per microliter. This is the summary of my initial explanation. And if there is no obvious infection site and patient is still febrile, then we add broad spectrum antifungal agent. So in case of this antifungal agent, the most common fungal infections are the Candida and Aspergillus. These are the two most common organisms of fungus. So we add antifungal agents if the patient is febrile for like more than 4 to 7 days, and the patient is also, if not resolving, then we add this antifungal agent. Previously we used to add the amphotericin B liposomal form because it has less side effect. And now the azole groups are added, like fluconazole, voriconazole and posaconazole. As we all know that no single antifungal agent is effective against all group of fungus, so we choose the antifungal agent uh, to their spectrum. And like if the patient is afebrile, if patient is afebrile and unstable or less than 72 hours of antibiotics, then we continue the regimen. And if the patient is stable after 72 hours of antibiotic, we stop the antibiotic treatment, as I have already mentioned here. So I will just briefly talk about the prophylaxis. So uh, if the patient is suspected to have neutropenia, if any patient is suspected to have neutropenia, then we add fluoroquinolones. And if any patient is receiving more than more than more than maintenance dose of more than maintenance dose of steroid, like in case of diffuse lymphoma, or if the patient is under maintenance for ALL, then we add trimethoprim and sulfamethoxazole combination, because there can be risk of because there can be a risk of due to risk of pneumocystic infection. So this is on prophylaxis. Now let's talk briefly about the viral infection which can occur during this febrile neutropenia. So the most common infection is herpes infection. In herpes infection, it is most commonly HSV, HZV, and there is one which is the Kaposi sarcoma associated virus. Kaposi sarcoma associated virus. It is the human herpes virus 8. This is one of the most commonly asked viva question, and we have to know that. And also there can be risk of cytomegalovirus infection if there is in case of in a patient with undergoing the hematopoietic stem cell transplant. And its treatment is the acyclovir. We give acyclovir and their derivatives. But we also give additional influenza vaccine if there is risk of respiratory infection. Now finally concluding about is there any other methods which we can use during this febrile neutropenia? Yes, there is one, the last method, which is giving the cytokines, that is granulocyte, colony stimulating factor, and granulocyte macrophage colony stimulating factor. We only this give cytokines if there is a severe neutropenia, if there is severe and prolonged neutropenia. In this case only we give the cytokines. Do you remember one thing, that if there is decrease of neutrophil count, then why we are not giving the neutrophil directly through blood? Because it is because if there is a granulocyte transfusion, actually it is very short half-life. And there is mechanical fragility. It can break down, so its level cannot be raised for very long period. So we do not prefer to give granulocyte transfusion. And there is a very or no response to any granulocyte transfusion, so we do not prefer this. All the information which I have given here is uh, basically from the Davidson and Harrison. uh, there is no any other information which is added from my side or any other books. So if you enjoyed the video, and if you have learned, or if you have been asked this topic in your exam or viva, please mention in the comment, and do not forget to like, subscribe, and share my channel to your friends and friends, and thank you.